Good morning. So we're going to get started. I know that we have kind of people still coming in and then some people who are watching on live stream. So let me introduce myself. I'm Dale Wolf. I'm a pastor here at Lighthouse Church, and our church is a recovery-based ministry as well as a behavioral health provider where we have done services in programs like 1915I, Free Through Recovery, and Community Connect. And for about half of this year, all of this year, we have been operating a recovery center, the Hope in Recovery Center, out of our properties and in downtown Fargo. And so we've spent quite a bit of time working in the behavioral health world, gotten to know a lot. Many of us, not only about some of the addiction issues that many of us here deal with, but also mental health issues. And I have learned over my time in my Lighthouse ministry that one of the most common conversations that I have around here is, are you taking your meds? Are they working? If you're not taking your meds, why aren't you taking your meds? Why did you stop on your own? All those kind of things that go along with that. And we have, as a community and as staff here, have really come to learn that it's kind of a key issue that we deal with on a very regular basis. So we have invited Dr. Amy Werremeyer to come in and share with our staff today. And we have decided to invite anybody else who's interested in coming to listen, especially providers, not only here but throughout the state. So I know that there's at least a few people on live stream who want to welcome you. And I can tell you that you're going to be really blessed by the information that you receive. You better buckle up because Amy has a lot of information that's going to be of value to us and will be beneficial to all of us. So I have known Amy for a long time. Amy, as you can see on the screen, if you can read that, is the professor and chair of the NDSU School of Pharmacy, and she has been very gracious to come and teach us here at Lighthouse about her expertise, and we want to welcome her today. Let me just say that if you, most of you know, but there's a bathroom up here, 2 bathrooms downstairs, there's coffee and things outside. Please help yourself. Also, there will be a break kind of in the middle and an opportunity for question and answers later. So why don't you welcome Amy.
Good morning, everybody. Thank you so much for having me. It's really a pleasure to be here. I love talking about mental health medications, so when Dale says that there's a wealth of information, there is, because I could go on and on and on and on. So you might have to stop me at times and remind me that we have to take a break. Or we want to take a break, I suppose. So as Dale mentioned, I'm a pharmacist, I'm a pharmacy professor, and I'm a psychiatric pharmacist. A lot of people don't know that that's a thing, but it is. So just like a medical doctor can specialize and become a psychiatrist, a pharmacist can specialize in different areas and become, like I am, a psychiatric pharmacist. There are about 3,000 of us in the country that have specialized in psychiatry and are board certified in that area. So that means that I learned about all of the other non-mental health medications and still work to manage them in my practice, but I have focused especially on mental health medications, so that's what we're going to talk about today. I put together just a really broad kind of overview and high-level look at mental health medications, but my presentation style and what I enjoy most is really kind of drilling down to what it is you want to know. So I'll kind of start us off with some of the basics and kind of overarching concepts about these meds, but I really welcome your questions, your comments. This can be as interactive as we like it to be, and that's generally my preference. So feel free at any time to raise your hand. I know we have microphones that can go around, but I will also do my best to repeat questions so those of you that are on the live stream can also hear what we're talking about in the room. So I also have a handout. I don't know if any of you got that when you came in, but it's just a copy of the slides that'll be on the screen, and they're not highly packed with information per se, but they're, like I said, kind of a framework and guide for what we're going to talk about. So if you want to follow along and take notes, or if that helps to jog your memory for questions or whatever, that's great. Just so I know who I'm talking to and what your kind of baseline ground level understanding and experience with mental health medications is, would you give me raise your hand if you have already been in some kind of mental health medication training course at some point in your career? A few, okay. And would you raise your hand if you yourself have taken a medication for mental health reasons? Okay. And if you are currently or have recently been working with clients who are taking mental health medications? Okay. Do you already have a bank of questions that you want to ask and that you're like, I'm not sure, I've dealt with this in my work and I don't know how to address it? You have things like that already in mind? Doesn't look like it yet. Okay, sounds good. So we'll just get started, and feel free, as I said, to jump in with anything that you've got as we begin to talk. So Claire, you can go to the next slide. Okay, so before we can really talk about what the medications that treat mental health conditions do, it's important we kind of back up and think about what's the brain doing before we can think about and understand how the medications are working in the brain. So this is a really zoomed in view of two nerves that are talking to each other. So you probably are familiar with the idea that our brain is essentially filled with a bundle of nerves. That's what it is. That's a bunch of nerves. Another word for that is neurons. And so neurons have a cell body, like a main area in the middle, and then they have branches that go out in a bunch of different directions. And all the nerves are shaped essentially like that. They have a cell body and then these branches that go out in all different directions, but they never actually touch each other. And that's different from all the rest of the cells in your body, where those cells, like in your kidney and in your heart and in your muscles, they all touch each other, and their walls have tiny little holes in them, so they can just share substances and information right across their walls. They don't need any specialized way to communicate with one another or to create the same environment across a large number of cells, because they're touching, they're in direct contact, they can just do that pretty fluidly, seamlessly. But neurons are not like that. They don't actually ever touch each other, but their branches reach out toward one another. And there are branches that are responsible for carrying information away. They're called axons, so alliteration there, axon away. And then there are dendrites, and they're responsible for receiving information from another neuron and taking it toward the cell body for processing, or toward the middle. But every nerve will have its own axons and dendrites. So every nerve is able to receive information and give off information. And you can kind of think of them in a chain. So there's a nerve, and then it's connected, or not directly connected, but reaching out toward its next closest nerve, and then that one's reaching out toward its next closest nerve, etc. Questions so far? So this picture that we're looking at is a really zoomed in view of the end of one axon that's carrying information away from the cell body. That's on the left-hand side in this picture. And then the beginning of a dendrite that's receiving information, that's on the right-hand side of this picture. So that dendrite that's on the right-hand side is then going to carry whatever information it receives to its cell body for processing, and then give off messages to the next nerve in the chain, essentially. Okay? So information that is communicated in nerves is always as an electrical impulse. So you probably don't think about your brain as like an electrical circuit, but that's essentially what it is. And so any kind of information that we receive or process in our brains is an electrical signal. So the fact that you're hearing my voice right now and you're understanding the words that I'm saying, that's happening because the nerves in your ear are initiating a process, because your eardrum's rattling around in there, and they're initiating an electrical signal that then connects to the nerves in your brain, and those nerves in your brain receive that information, and they send all kinds of signals back and forth to make sense of the information that I'm saying, to even determine, do you recognize my voice? Have you heard it before? To recognize, have you heard any of this information before? And that's all happening like with electrical signals going back and forth literally millions of times per second. So not only does that happen when you hear, but it happens when you, like for example, if you're wearing socks right now, your brain is actually receiving information from the nerves in your feet that you have socks on right now. You get that signal over and over and over again all day long, as long as you're wearing socks. But after a few seconds, your brain's like, yeah, I got it. I know we're wearing socks, so I'm not going to pay attention to that signal anymore. And because of the brain's ability to kind of filter and, I guess filter is the best word, kind of almost like cancel electrical information that it's receiving, it can decide what it's going to pay attention to and what it's not going to pay attention to. It's really kind of miraculous when you think about that that's happening millions of times per second all day long in your brain, and you don't even realize that that's all taking place. But thoughts and emotions are also part of this exact same process. So every time you have an emotion or every time you have a thought, it's because your brain is processing information in electrical signaling format. So when, let's say for example, I just woke up this morning and I am like, oh, today is a regular day. I got a long list of tasks on my to-do list. It's a Wednesday. It's not Friday, but it's Wednesday. So I'm not like jumping up and down excited to get out of bed and tackle my weekend and enjoy it. But I'm also not like, oh great, it's Monday. Ugh, here we go. So when I'm in that sort of like regular, this is my life, I'm ready to engage in it, but I'm not bouncing off the clouds, and I'm also not down in the depths of despair. I'm just in my regular mode. My brain has sort of a set of electrical signals and messaging that it's going to use to carry out that information and kind of permeate my brain in that sort of mode or mood, you might think of it as, okay? So our moods are controlled by this kind of electrical signaling process too, in very complex patterns. And what I just said was a really significant oversimplification of what that looks like, but that's the gist of what's happening. So let's say that I woke up, my brain is in this kind of mood maintenance mode where I'm fine. I'm not ecstatic and I'm not super depressed, I'm just fine. We're gonna call that a mood maintenance message, okay? So that's the electrical signal that then the neurons in my brain are gonna be sending. And the more times that message gets from one nerve to the next, to the next, to the next, to the next, the more likely it is that that's the sort of environment that the majority of my mood center in my brain is going to be bathed in. And that's essentially what the output then of my mood will be. I'm fine. I'm not, way up in the clouds, and I'm not terribly depressed. I'm fine. I'm in my mood maintenance mode. The technical term for that is euthymia. E-U-T-H-Y-M-I-A. And that literally means true mood in Latin. So that's just your regular maintenance mood. So when my brain is sending that kind of signal, it's going to start from left to right in the presynaptic neuron. And if you're looking at the picture on the screen on the left-hand side, look all the way at the left. The electrical signal is going to be kind of like a line coming down that left-hand side nerve, that presynaptic nerve. And you can see a bunch of bubbles in the picture where there's like a larger bubble and then a bunch of little bubbles inside. So when the electrical signal gets to the end of that nerve and it reaches the point where all those bubbles are, it actually activates those bubbles because the signal is going to turn from an electrical signal into a chemical signal, and those bubbles represent a bunch of different chemicals in the brain. The chemical part is necessary for the signal to jump across the space between nerves. The electricity can't travel between those two nerves by itself. It has to turn into a chemical form in order to get across the space between the nerves and then resume into an electrical signal on the other side. Those of you who know God, doesn't this blow your mind? God made all this and controls it all and knows how, taught us through thousands of years of scientific discovery how to help manipulate those chemicals and this electricity activity in the brain. I just think that's fascinating and so inspiring. I love it. So the electrical signal gets to the end of the nerve. It's going to activate one or more of those bubbles. So you can see on the left-hand side where one of the bubbles is kind of merged with the outside of the nerve and it's starting to spill its contents out into the space between the nerves. That's how the signal is transferring from an electronic or electric signal into a chemical signal, because those smaller bubbles are bits of brain chemical. Anybody know any names of brain chemicals that you've heard of before? I heard dopamine. Serotonin, exactly. Any others you know of? Norepinephrine, have you ever heard of that? norepinephrine. Even adrenaline, you may have heard of like when you get an adrenaline surge, adrenaline is also a brain chemical. There are lots and lots of brain chemicals. We're mostly going to focus on serotonin, norepinephrine, and dopamine when we talk about mental health medications because those chemicals are most responsible for carrying on the kinds of signals that we need to maintain our moods, to maintain our attention, and to help us filter out information that we don't need to pay attention to. So serotonin, norepinephrine, and dopamine are the most important chemicals for mental health impact. Okay, where was I? So the signal gets to the end of the nerve, it spills out it causes activation of those bubbles, and depending on the kind of information that the electrical signal contains, that may cause different brain chemicals to become activated and spilled out into the space between the nerves. And it probably is even the case that like my mood maintenance message might dump out different amounts of serotonin versus dopamine than yours. We actually don't have very good ways to measure that. In research studies, they can determine through pretty complicated imaging processes how much serotonin someone has in their space between their nerves compared to how much dopamine they have in their space between their nerves. But when we try to make sense of, well, what does that mean? If I have 100 serotonins and Dale has 50, what does that mean? We really have no idea. It doesn't consistently tell us useful information because it seems that everybody probably has their own threshold for what amount of serotonin they need to get their mood maintenance messages working and what amount of dopamine they need to keep them going, for example. And across a whole group of people, it's really inconsistent and not very helpful to measure. So once the signal has been transferred from an electronic signal into a chemical signal, and the bubble has sort of opened up and is causing the brain chemical to be spilled out into the space between the nerves, which, by the way, is called the synapse. In this picture, it's labeled as the synaptic space. Same thing. Synapse or synaptic space are interchangeable. The chemical molecules, then, those smaller circles, they now have the information. They're carrying the signal. So if we're talking about a mood maintenance message, that message now resides with that brain chemical. And if it doesn't get to a receiving receptor on the postsynaptic side, on the nerve on the right-hand side, then the message dies, basically. It does not get carried on. So that chemical molecule needs to land on what you see labeled as receptors on the right-hand side of that picture. And once it does, once the chemical lands on the receptor, then that initiates a complex process that turns the signal back into an electronic signal or an electricity vector, basically. And that will bring that information to the cell body. And then hopefully that process is going to happen again at the next nerve connection, and again at the nerve next connection, et cetera, et cetera. One thing I don't think I explained on this picture is that the name for the collective group of brain chemicals is called neurotransmitter. So you can see on this picture, the smaller circle is labeled as neurotransmitter. So serotonin is an example of a neurotransmitter, dopamine is an example of a neurotransmitter, norepinephrine, et cetera. So that's just a fancy name for saying brain chemicals. One more thing we need to say before we move on from this picture, and that is that our brains are very good housekeepers of the synaptic space. Our brains don't like when the synaptic space gets cluttered and messy, so we have lots of cleanup mechanisms for it. Some of those involve what are called enzymes. You may have heard of enzymes before. They're things that our bodies make and sometimes put into our brains, or some of them are made right in our brains. And those are like Pac-Man, and they just come along and chew up brain chemical and get it eliminated out of that synaptic space. And we know for a fact that some people have really active Pac-Men in their brains, and some people have less active Pac-Men in their brains. And so that can make a difference in how quickly they clean out the space in between their nerves. The item on this picture that's labeled as the transporter, you could also think of that as a vacuum. So it sucks up stuff from the synaptic space and brings it back into the presynaptic nerve for repackaging and reuse, generally. Sometimes it's broken down and eliminated from the body entirely, but often it's repackaged and reused. So the transporter is also helpful in cleaning out that synaptic space. It's sucking up stuff from the synaptic space and keeping that area cleaned out. Are you on information overload already? Do you have questions? Okay, let's go on to the next slide and start putting some of this into more practical terms. So we're going to start talking about antidepressants. This, as you see on this slide, this is one class of antidepressants. The SSRIs, I'm guessing you've probably heard of SSRIs before. They're very commonly used. They're the first choice of treatment for depression. And so they're often kind of household names that you might have heard of. And you're probably also familiar with the fact that pretty much every medication has both a generic name and a brand name. The brand name is what the company who developed the medication called it and copyrighted it as, or trademarked, I guess it would be. And they're the only people who get to make money by calling that medication that name. Okay? Everybody else who might begin to make that medication, once the patent has expired, they have to call it by its generic name, not its brand name. Every other company. But you might have noticed also that in the healthcare world, we're pretty bad at going back and forth between the brand name and the generic name and not telling anybody that we're doing that. So if you can have familiarity with the brand names and the generic names of medications, that's probably going to help a lot with translating information or helping your clients to remember which directions went with which medication or which medication their doctor's talking about changing because their bottle says Celexa or the bottle says citalopram, but the doctor's calling it Celexa or what have you. I'm guessing you may have experienced that before. Okay, so antidepressants, this group of antidepressants especially, they work by blocking the transporter on the presynaptic nerve. Claire, will you go back to the previous slide? So that thing that kind of looks like an equal sign that's labeled as transporter, the vacuum in the brain, SSRIs work by sitting in that vacuum and blocking it. So it's kind of like when you suck up a sock in your vacuum and it's not going to work anymore. Like at my house, there's dog hair and crumbs all over the floor. Well, that happens in the synaptic space. You get serotonin hanging out in that synaptic space longer when the vacuum is blocked. And the dog hair and crumbs are not necessarily a good thing at my house, but in this case, when people have depression, that is a good thing to have more serotonin hanging around much longer, because that means that more of those mood maintenance messages are going to be able to have time to get across to the receptor that they need to land on to reinitiate that signal in the connecting nerve. And that means that more of that message is going to get through the brain and bathe the brain in that I'm okay kind of environment. So a few take-home points to talk about with SSRIs. One is that it's important that we have realistic expectations about what an antidepressant, really any antidepressant, including SSRIs, are going to do for someone. They're not going to make them feel like they're in the clouds and that everything is great every day and life will be perfect from here on out. That's not even healthy, generally. But they have a better chance of putting someone in that I'm okay kind of mood environment. And I think sometimes people have that as a realistic expectation, but others may expect that the antidepressant is going to make them feel good instantly and for always. And that's generally not the case. Also, it's really interesting that we know that the amount of serotonin in the synaptic space goes up within 24 to 48 hours after someone starts taking an antidepressant or an SSRI in this case. So right away, the amount of brain chemical that the brain can use is higher. But does anybody know how long it typically takes for an SSRI to feel like it's working? I think I heard someone say 6 weeks. Yeah, 4 to 6 weeks is very typical. Sometimes it's even longer, up to 12 weeks. Sometimes people will notice some changes in 1 or maybe 2 or maybe 3 weeks. So the theory, we don't know exactly why there's such a delay, but the theory is that what needs to happen is that extra serotonin that stays out in that space longer actually has to cause the brain to start to recruit new nerve connections to grow into this space so they can also use the extra serotonin that's available. And that takes longer for the brain to be able to grow new branches into different areas to use the extra brain chemical that's now available. And it turns out that the timing of the brain's ability to grow new nerve branches fits about exactly with the timing with which it takes antidepressants to start to work. So that's probably what is behind that delay. So we really try to encourage people to keep taking an antidepressant even when they feel like it's not working, at least for a 12-week time frame. Sometimes if their symptoms are very severe, we might get on the stick and try to make changes or adjustments sooner than that and discontinue an antidepressant, start a different one. But we do know that we can continue to see benefits out to 12 weeks, even if we haven't been seeing them early on. And also when people start to take antidepressants, it's very common that there's kind of a 1 step forward, 2 steps back, or 2 steps forward, 1 step back kind of pattern when they start to see improvement. So it's very rare that someone would, let's say 9 days into taking their antidepressant, continue to report they feel like garbage, and then on day 10, all of a sudden, they're better and they stay better forever. It's more like, well, I kind of noticed that I watched a whole hour TV show and I could concentrate on it, and that hadn't been happening for me for a while. And then the next day, no, I can't concentrate again today. But then the next 3 days, I might be able to concentrate a little better. So that kind of like back and forth pattern, really common. We tend to see things like people's appetite and maybe their concentration. Sometimes their energy levels start to improve earlier than their overall feeling of like, yeah, I feel better, I feel good, I feel like the fog has lifted. That tends to take longer. We also know that, unfortunately, antidepressants don't fix this whole neurotransmission setup. So they're not permanently able to make your brain keep its own serotonin around longer for better use. And if someone stops taking one of these antidepressants, the brain will typically revert back to its previous pattern of serotonin availability, meaning generally less serotonin availability. So antidepressants don't cure depression in terms of making it go away forever. They're a maintenance kind of medication, and we know that they reduce the risk for relapse of depression, but they don't eliminate the risk for relapse of depression. The research would say that people who have depression and continue taking their antidepressant for the recommended length of time, which varies depending on how many times they've been depressed, they have about half the risk of relapse, meaning having their depression come back again, compared to people who don't take their antidepressant for the recommended length of time. And if an antidepressant is stopped all of a sudden, kind of cold turkey, the system has to rapidly adjust back to the way that it was before, and it kind of doesn't like that. And so there is what's called a discontinuation syndrome with antidepressants, where if you stop one all of a sudden, the amount of serotonin in the brain goes down pretty quickly, and then people kind of feel yucky. They kind of feel like they're coming down with the flu maybe, really achy, really tired, headache, pretty common. They can have a worsening in their mood or anxiety. And then there's kind of a specific thing that happens only with antidepressant discontinuation, and it's called electric shock-like sensations. Sometimes people call them the zaps or the zings. It's just like it sounds, a little bit of like electric shock-like sensation. Sometimes people describe it as like a flash in their brain. This is not harmful and it's not permanent, but it is known to happen when an antidepressant has been abruptly discontinued. They will go away with time, maybe a week or so, but they're kind of uncomfortable, and best that we gradually decrease the amount of the antidepressant that someone's taking rather than stop it cold turkey to avoid this whole situation. People have often asked me, so does that mean does the fact that I have like a discontinuation syndrome when I stop taking an antidepressant, does that mean that I'm addicted to it? And that is completely not true. Antidepressants are not addictive. And what I mean by that is that people don't steal to try to get antidepressants. They don't abandon their families when they're using antidepressants because they're so focused on using their antidepressant and obtaining antidepressant to use and overuse. So they don't bring about the kinds of patterns of behavior that other substances that are addictive can, things like alcohol or heroin or even cannabis. But the brain does adapt to them being around. And that's different than becoming addicted to something. But an adaptation to the medication, that's actually what we want to happen. We want our brains to adapt so they're working better and keeping us in a mood maintenance kind of mode. But that doesn't mean that there aren't impacts if the medication is stopped. So is that making sense? Okay. I have one more point to make about antidepressants before we talk a little bit about anxiety. So if I lose my train of thought, somebody remind me that we're going to anxiety next. People have also often asked me, well, what about if I use a substance when I'm taking an antidepressant? Because oftentimes the bottle that you get from the pharmacy will come with a little sticker that says, don't combine with alcohol or other addictive substances or what have you. So there's kind of a lot to consider when you think about using substances with an antidepressant. And I mean, generally the message is don't use substances when you're taking an antidepressant or when you have depression, period, because they're counteracting each other. But the explanation for that is that when you use a substance of abuse, your brain has a ton of electrical signaling happening in a very fast and large quantity. So the left-hand side nerves are dumping out a lot of brain chemical all at once, much more than you would ever dump out into your synapses with any other activity. So you might be familiar with the fact that like eating food that you like causes your brain to dump out a little bit of pleasure chemical because that's signaling to you that this was good, let's do this again, I like this. When you engage in positive social interaction with other people, your brain also dumps out a little bit of pleasure chemical as well as serotonin that tells you again, this was a positive experience, I should do this again, this was good. When an abusive substance is used, somewhere between 10 and 500 times the amount of brain chemical is dumped out all at once. So just think about that you're dumping out a ton of brain chemical into the synaptic space when a substance of abuse is being used. And your receptors can't even use it all because it's just inundated, there's too much. But the bubbles on the left-hand side then, they get depleted because they don't have an endless supply of neurotransmitter to fill those bubbles. And so when it comes time for your brain to be able to send mood-maintaining messages, let's say the next day, there's not very much material to work with. It takes a while to regenerate those molecules back into their bubbles where they sit, waiting to be used. And so we know that use of abusive substances in combination with antidepressants often means the antidepressant can't work as well because it just does not have the material it needs to work with in order to keep the mood maintenance messages getting through. So I often will tell people, using an antidepressant and drinking alcohol, it's not like a bomb's going to go off in your bloodstream and bam, you're going to have terrible consequences. You might. But really, it's kind of you're undermining what your medication's trying to do and undermining your brain's ability to adapt and get into a healthier pattern with how it's using its brain chemicals. So for people who maybe are able to, let's say, keep it to one drink doesn't turn into 7, or they have had their mood fairly well controlled for several months, the risk of having one drink is probably pretty low in terms of their depression control. Now, I'm not talking about maybe their addiction control if they have that as a comorbid condition. But if they are a person who either of those two criteria aren't met, like their mood hasn't been well controlled for a period of several months, or they are a person for whom one drink turns into several more, then the risk is quite a bit higher to have any amount of alcohol consumption while they're taking an antidepressant. Why do antidepressants not work for some people? The question is, why do antidepressants not work for some people? I wish I could give a 100% definitive answer to that question, and if I could, I probably would have like $1 million mansion somewhere and maybe a fancy NIH lab, because we don't know for sure. But there are several theories. The simplest theory, I guess, is that the transporters that you see in this picture, every one of us has slightly different shaped transporters. And if you think about the kids' shape sorter toy, where you can only put the star in the star shape and you can only put the square in the square shape, so antidepressant medications also have a chemical shape. And sometimes there's a really good match between the shape of the antidepressant and the shape of that person's transporter. So the medication fits in there really well, it's a strong blocking sock in their vacuum, and they get good effect from it. But we can't tell by the shape of the medication exactly for whom it's going to work, because we don't have just a database of transporter shapes for everyone's brain. Maybe someday we'll get to that point, but right now, I have no idea, Dale, if your transporter is shaped like a star or a circle or a square. I don't know for mine either. And so we can't match medications well to people's shapes, basically. That's probably at least 50 years in the future if we ever get to that point. But we know that that could be a possibility. So that's one possible explanation. Another is that it's very likely and becoming increasingly clear the more we do research that we have lumped all the people who have symptoms of depression into one basket because there's commonality in their symptoms, but it's very likely that actually the process of disease in their brain is different. So for some people, it may be that their serotonin system isn't functioning very well, and so when we use antidepressants that target serotonin, we can get good effect. But for other people, it may be that the process that requires their receptors to initiate the electrical signal isn't working very well. That's what's leading to their depression. And the antidepressant itself doesn't fix that part of the process. It's also possible that there are causes for depression and processes in the brain associated with depression that we don't even understand yet. So there probably are lots and lots of different subtypes of depression that would need different treatments than antidepressants, but we don't at this point know how to figure out what those are.
And why do they stop working?
Why do they stop working? Also a very good question that has no good answer. It probably has to do with the brain's ability to adapt and readapt over time. We used to think that the brain was this static organ, that you got a brain when you were born and good luck to you and use it well. But now we know that it's constantly changing and revamping kind of the way it's built. And that's actually healthy. We know that when people's brains stop revamping the way they work and stop pruning themselves, that's a sign of dementia or other like irreversible disease processes. But because the brain is constantly adapting, it seems that it may sort of adapt itself out of the beneficial effect of an antidepressant. But exactly how that's happening or why that's happening, we don't know, and how to stop it from happening, we also don't know. It is known that antidepressants can stop working, though, and that goes by the highly technical term of the poop-out syndrome. The poop-out syndrome. So it was working for you for a while, and then it pooped out on you. The good thing is we know that doesn't mean that doesn't have any bearing on whether other antidepressants will work for someone, because it's likely that the other antidepressants still will work for them. And after a period of time of being off the antidepressant that pooped out, there's a fairly good chance that going back to that antidepressant will bring about benefits again. So it's kind of like you have to allow the brain to unadapt and readapt and unadapt and readapt at times. Other questions? Is there a time you can figure that you should switch up your medication? So I alluded to a little bit of this before when I said that the recommended amount of time for an antidepressant varies by the amount of time someone has been depressed. So the recommendations are that if someone is in their first or second time of having depression, that they take an antidepressant that's a dose that's working for them for at least a year. After a year, then you can reevaluate. Is the antidepressant still needed? Are things going pretty well? If your dog just died and you just got divorced, that's probably not a very good time to stop taking an antidepressant. So the 1-year mark is not hard and fast, but it's a guideline for consideration. If someone has had more than 2 times where they've had severe depression, then we usually recommend that they take an antidepressant lifelong. And that would be that they continue taking whatever antidepressant is working as long as it keeps working. But if the efficacy starts to wane, then we would consider switching out or considering other options. Or sometimes we'll add on to try to preserve whatever efficacy still remains, but give it a boost so it'll work a little bit better going forward. But there's not like well, if you've been on the same one for 5 years, that's bad and it's time to revisit. Definitely not. Mm-hmm. Yes? How important is it to take meds at the same time every day? With antidepressants specifically, it's important for kind of routine establishment and kind of getting the pattern established that you take a medication every day. But in terms of your brain's ability to adapt, it's not super important that you're real rigid taking it at the same time every day. Taking it every day, though, is kind of the key. So if you take it at 8 a.m. one day and then you sleep till 11 the next day and take it then, that's not a problem. But taking it every day and avoiding skipping doses would be the thing I would zero in on. With most of the SSRIs, Claire, will you go to the next slide again? With each of these medications, we usually recommend that people start taking them in the morning, except for Paxil or paroxetine. That one we usually recommend people take at night because it is more sedating. But if people so not everybody gets sedated from taking Paxil. So if they start taking Paxil at night and they find that it's keeping them awake, it's fine to switch to taking in the morning. And any of the others, it's fine to switch to taking them at night. It's not great to take them in the morning for 3 days and then take them at night for 6 days and then go back to the morning for 2 days and, that's not ideal. It's better than not taking it at all. But there's some flexibility with the time of day they can be taken and then switching it if need be to fit how your brain responds. If you feel drowsy by taking it in the morning, then you can switch it to taking it at night. Did that answer your question? Okay. Okay, I remembered my own next direction, which was to talk about anxiety. The coffee is working. So we've been talking about antidepressants, and that's the name for this category of medications, but they are all also anti-anxiety medications. And they're the first-line treatments for anxiety, in addition to being the first-line treatments for depression. And probably the reason for that is that anxiety is maybe even more so impacted by serotonin than depression is. And so by impacting serotonin, making it stay around longer in the brain and be more usable for the brain, we can impact both of those simultaneously. We also know that the more mood maintenance messages that the brain gets through, the fewer anxiety type messages it's able to communicate along that same network. So it's kind of like if you have the train going on this set of tracks, it's occupied, and the anxiety train can't get its messages through as well. So that's part of how these medications can help with anxiety. But just like we talked about with depression, they take a long time to start working. 4 to 6 weeks is very common, and sometimes a little bit longer. And particularly with anxiety, sometimes it gets worse when these medications are first started. And that's obviously very disappointing and can make a lot of people just say, forget this, I'm not taking this medication, it's making me feel worse. But we know that's a side effect of early use of an antidepressant, or even right after having a dose increased, that can happen as well. But it's a short-term side effect typically, and it tends to go away within 1 to 2 weeks of either starting the medication brand new or increasing the dose. So if we can kind of coach people to keep taking it despite feeling worse, which I know is hard to do, and we have to encourage lots of other coping strategies and supports, obviously. But it's pretty common that they'll get past that early worsening, and then have kind of a lull where it seems like nothing's happening, and then get to the point where it's bringing about benefit. And again, it's not the kind of relief that maybe would be considered like rapid and complete when treating anxiety, but it's more likely that the person will be able to recognize they're experiencing anxiety and think about how can I take steps to control this anxiety right now, rather than having immediate panic type reactions to the anxiety sensations or signals in their brain. So it's not a complete damper on anxiety, and it doesn't prohibit any anxiety type information happening in your brain, but it helps to reduce the severity of it and helps to make it more manageable over time. Yes?
Is it true that it's harder to medicate for anxiety and you typically need a higher dose of medication?
Yes. We often need to use the very top doses of these medications to get anxiety under control, whereas depression we may get by with using lower doses. But we also try to start at lower doses when we're treating someone with anxiety with these medications because of that early onset side effect I was talking about, because we don't want to slam them with a severe side effect like that and make it so that it's just intolerable. So the mantra with using antidepressants for anxiety is start low and go slow, but aim high. Yeah. I was going to add something else about anxiety. What was it? The timeframes for use of these medications for anxiety is similar to what we talked about with depression. So the kind of 1 year time frame for if you're kind of in your first or second time of having very severe anxiety, but much longer time frames, maybe indefinitely, if you've had more than 2 times where your anxiety has been bothersome and severe. That wasn't what I was going to say, but I can't think of what it was. So, any other questions about SSRIs? Correct. All of these are good for both depression and anxiety that you see on the slide right now. Yep. Okay, let's go to the next slide. Just when you thought you're getting it understood, now we got to increase the complexity. So this class of antidepressants is called the SNRIs, and that stands for serotonin and norepinephrine reuptake inhibitors. I think I forgot to mention that the reuptake inhibitor part refers to the action of the medication. So the transporter that we saw in the picture is actually called a reuptake pump. So the SSRIs are inhibiting the reuptake pump, aka they're a sock in the vacuum. And then the SNRIs are a sock in 2 different vacuums at one time, the vacuum that would suck up serotonin and the vacuum that would suck up norepinephrine. So yes, for the SNRIs? They are blocking the reuptake pump, or the vacuum, for both serotonin and norepinephrine at the same time. Mm-hmm. So that maybe might sound like, well, why wouldn't you always use one of these? You're getting 2 for the price of 1. And we did initially think, well, that's obvious. We should use 2 for the price of 1 whenever we can. But that hasn't turned out to be the case, because we now know that these are not always more beneficial for someone compared to an SSRI. And some people will do better on just an SSRI, just having 1 brain chemical impacted, and others will do better by having 2 brain chemicals impacted. But we can't tell by looking at you, by your symptom presentation necessarily, by your family history. We can't tell which of the brain chemicals you need impacted, whether it's both or neither or 1 at a time. Norepinephrine is like a lighter version of adrenaline. Adrenaline, the actual chemical name for it is epinephrine. So norepinephrine is really similar to epinephrine. And think about for a minute what happens to you when you get a surge of adrenaline. So let's say you're driving down the road and the car in front of you slams on their brakes and you have to slam on your brakes super fast. Well, actually, this happened last night. My husband and I were driving on the interstate. Bam, hit a deer. Talk about adrenaline surge all of a sudden. Okay, what do you feel? Heart rate goes up. Shaking. Sweating. Stomach upset. Also energized. Like you could lift up that deer if you had to, right, and get it out of the front grille of your car, because you're empowered. Your adrenaline is giving you some activation and some energy and motivation to address whatever the crisis is. So when you think about that, that's what adrenaline does. So norepinephrine does almost all those exact same things, but on a smaller scale. Okay, so it's a lighter, less potent version of adrenaline. And if you're thinking about what you experience when you're getting a surge of adrenaline, it kind of seems like, well, why would I use this? Why would I want adrenaline or something similar to it if I have anxiety? Because that shakiness and maybe even the stomach upset and the heart rate going up, that seems counterintuitive for someone who has anxiety, and it is. It is counterintuitive. And sometimes people's anxiety gets a lot worse when they take these because of that norepinephrine action. But sometimes people's anxiety gets way better when they take one of these, despite that norepinephrine action. And we don't have a good explanation for why that is, except we know that serotonin, norepinephrine, and dopamine are kind of like the president, the Supreme Court, and the legislature in the government. They all have checks and balances over one another. So when we increase the action of one, let's say serotonin, which each of these medicines is more potent for increasing the amount of serotonin available than they are potent for increasing the amount of norepinephrine available. So likely the serotonin action will override the norepinephrine action for many people, but not everyone. And that's why sometimes people get worse when they take these compared with better. So if it sounds like a lot of trial and error, unfortunately it is. It is a lot of trial and error because we just don't have the precision tools we would like to have to be able to tailor these treatments better. Let's see. For depression, you might think about, well, if I'm getting adrenaline action, that can increase my energy level, it can increase my motivation, it can increase my concentration, and those are good things for depression. Those are the kind of the opposites of some depression symptoms. And so we have that kind of logic supporting why we might use one of these medications. But again, on the whole population level, these are not better than SSRIs. If we take 500 people with depression and put them on an SSRI, 500 people with depression, put them on an SNRI, about the same number in both of those groups are going to get better. But any one person taking an SNRI may feel way better than they did taking an SSRI or vice versa. Yeah? Combining. We don't want to do that. Not these two categories anyway, not the SSRIs and SNRIs. And the reason for that is when we have excess serotonin action happening in the brain, that's kind of, especially when it's artificial, like it's induced by an outside source, that can contribute to what's called serotonin syndrome. And that's a potentially very severe, actually potentially fatal reaction or consequence of having too much serotonin in the brain. Plus, it's not adding anything by combining these two together because our brains kind of have a ceiling for how much serotonin we can actually use, which is based on those kind of receptors on the postsynaptic side. So it's not any more helpful to use the two of them together, and it might get a whole lot worse, so we tend not to do that. Mm-hmm. There are other classes of antidepressants that we use together pretty often, but they work differently than these SNRIs do. Just a few kind of caveats about the SNRIs. They can increase blood pressure, so we typically try to monitor people's blood pressure when they first start taking one of these, just to make sure we're not causing them to have too high of blood pressure. That's usually a really short-term effect, though, because our bodies will adjust. So after 2 weeks or maybe a month, we don't have to be so careful about that. And this group, especially venlafaxine, they're known for their discontinuation symptoms. So when people stop taking these abruptly, they're typically going to feel it. They're not going to feel very good. And I've worked with people even who have told me that 23 hours after taking their last venlafaxine dose, they can feel the symptoms starting to begin. And it's kind of a reminder to take their medication every 24 hours because they can feel the symptoms if they don't. And finally, one of the ways that our brains adapt to chronic pain is by using norepinephrine released from the brain down into the periphery to basically shut off pain signals or kind of tell them to stop. So one of the ways, like when I told you that your brain's getting information that you're wearing socks, if you're wearing socks, one of the ways your brain ignores that information is by using norepinephrine. So norepinephrine can also be helpful to ignore pain signals that are coming from the body. And so we sometimes will use these antidepressants when people have chronic pain conditions like fibromyalgia or diabetic peripheral neuropathic pain, because it can help the brain to ignore those pain signals at times. And those pain signals aren't functional. They're not telling you to stop moving because you have an injury, like pain does after you have surgery or after you fall down the stairs or whatever. So chronic pain conditions we can treat this way by telling our brains to ignore the pain signals because that's not going to cause us further harm. We don't want to tell our brains to ignore pain signals when we just had surgery because those are functional. They're telling you need to rest. But in the case of chronic pain, that's generally not the case. And so these can help to increase people's function by ignoring the pain signals a little bit. So if someone were coming to talk about a new medication for depression or anxiety and they also had chronic pain, that might cause us to choose an SNRI first for them compared to having used an SSRI first. Otherwise, we typically will use an SSRI first, but if they have comorbid chronic pain, an SNRI would probably be preferred. Questions? Yes?
How does the antidepressant work with pain? Because I don't know oxygen. Pain with antidepressants.
You said you're taking one, you've known about someone taking one?
I'm on duloxetine for pain.
Duloxetine for pain, yeah.
Nerve pain. How does that, the difference between that and antidepressant?
Good question. So how does it tell the difference between depression and pain? It doesn't. It doesn't, the medications, we like to think of them as like knowing what they need to do and being smart about what our bodies need them to do. That's not true. They can't target anything unless we've designed them that way. So when you take like duloxetine, it's going to make more norepinephrine available in your brain, regardless of if you have chronic pain and depression, or only chronic pain. And that increased norepinephrine in the brain can help with promoting positive mood and energy and things, and at the same time, it can help with helping your brain ignore pain signals that are coming from your body. So if you take duloxetine and you don't have depression, it's not a problem. It doesn't cause you any harm. But if you did have depression, it would also treat that regardless.
So the nerve receptors are about the same between nerve pain and blocking in your head?
They're different. The nerve receptors in your body are different than the ones in your brain, but the medication's only going to be working in your brain, not the rest of your nerves very much. Yes, you're welcome. Okay, let's talk about one more group of antidepressants and then we'll take a break. So next slide, please, Claire. Okay, so this group of antidepressants is what I affectionately call the others because they don't fit in the category of SSRI and SNRI. They work differently, but they don't all work the same. In fact, each one of these works differently from its neighbor in the table. So they all have various ways of impacting the neurotransmitters in the brain. I'm trying to decide how to best explain this without going into lots of details about each one of them. They all have action, well, not all. Okay, I better just talk about them individually because otherwise I'm gonna lie. So bupropion, also known as Wellbutrin, does not work on serotonin at all. It blocks the vacuums for norepinephrine, which we've already talked about. That's like the light version of adrenaline. And it works on dopamine. So it blocks the vacuum for dopamine. Not very well. So we don't get a ton of dopamine when we use bupropion, but a little bit of dopamine when we use bupropion. And just to put that in perspective, if we were going to compare, let's say, 3 drinks of alcohol to bupropion, the amount of dopamine you would get from the 3 drinks of alcohol would be like at least 1,000 times more than the amount of dopamine you'd get from 1 dose of bupropion. Okay? So bupropion is not addictive because the amount of dopamine it can bring about is so small. And that's kind of an important thing to think about because we often generalize and say that anything that increases dopamine in your brain can be addictive, but that's not always the case. Bupropion is typically not addictive. Bupropion is not great for anxiety because it's working on norepinephrine, that potentially anxiety-provoking chemical, and it's not counteracting that with any serotonin. But we do use bupropion fairly often as an add-on medication for depression because if we're using an antidepressant that focuses mostly on serotonin, and then we add bupropion that also is focusing on norepinephrine and dopamine, sometimes that brings about greater benefit because we're kind of hitting 3 different brain chemicals at one time. Plus, bupropion is more likely to cause weight loss than it is weight gain. And sometimes it can counteract weight gain that people have had when taking their serotonergic antidepressant, their other antidepressant that works on serotonin. And it's activating. It tends to cause people to feel like they have more energy, or maybe they don't need to sleep as much. They're more able to be up and active. But the flip side of that is that it can make people have insomnia. So we definitely don't want people taking Wellbutrin at bedtime. It needs to be taken early in the day. Mirtazapine has a really complicated way that it works. It increases the amount of serotonin and norepinephrine, small amounts of norepinephrine in the brain, by blocking a different area on that neurotransmitter picture that we didn't really talk about, but it's part of the cleanup mechanism, which is that if there's a lot of serotonin out in the synapse, the brain will recognize that and it'll sort of shut off the flow from the presynaptic nerve, from the left-hand side. Well, mirtazapine blocks that initiation step, I guess, that step that would, let me back up and say that differently because I'm just confusing myself. Mirtazapine makes it so that your brain is less able to shut off the flow of serotonin from the presynaptic nerve. So I always think of like a sink. There's a little hole at the back, and when the sink's getting really full, the water starts to flow backwards so that the sink doesn't overflow. Okay, well, that's kind of how our synapses are. When there's a lot of serotonin in the sink, so to speak, in the synapse, it'll start to backflow, and it's going to land at this one spot. And that when it lands at that one spot, that would be what would normally cause the nerve to shut off the flow of serotonin. But mirtazapine sits there in that hole at the back of the sink so that the faucet can't get turned off. The faucet will still stay on. Well, which sounds like, well, isn't that going to make it overflow? And that's a possibility, honestly. But it doesn't tend to be a problem, again, because of the way our brains use serotonin. There's kind of a ceiling effect with how much our brains are able to use. Mirtazapine also is able to kind of tailor to where serotonin goes in the brain, which none of the other antidepressants are able to do, at least not the ones we've talked about so far. So we want serotonin to land on one specific type of serotonin receptor. It's called the 5-HT1 receptor. You don't have to remember that, but so mirtazapine blocks some other serotonin receptors that either cause side effects or are just kind of distractors that aren't helpful. And so by blocking those distractor ones and the ones that can cause side effects, that shunts more of the serotonin toward the receptor where we actually want it to go, toward the 5-HT1 receptor. So all that to say, mirtazapine can be a very helpful antidepressant and anti-anxiety medication all by itself. or we can add it to an existing antidepressant, a serotonin antidepressant, or even bupropion, because it's going to help to kind of put the pegs in the right holes when the previous antidepressant is increasing the chemicals in that space. Make sense? Okay. Vilazodone and vortioxetine are new-ish. They've been around for about a decade, but that's newer than any of the other antidepressants we've talked about to this point. They have actions that are very similar to the SSRIs, plus a little sprinkling of some additional action that nobody has a lot of confidence that it does anything extra. And they have a high price tag right now. Because they're brand name only, there's no generic available. So these are not getting a lot of use. They might be used when someone has tried a lot of other antidepressants and not gotten benefit. I have seen sometimes when people have responded to one or the other of these when other antidepressants haven't worked. But I've also seen plenty of times where they've been used in people who have had lots of other trials and they still didn't work for that person. So it's that trial and error thing, and these are at the far later end of what we might try. And then brexanolone and esketamine, you maybe have even heard about these in the news more recently because they're brand new-ish in the last few years, and they work completely differently. There's no action of these medications on any of the brain chemicals we've talked about so far. No serotonin activity, no norepinephrine activity, no dopamine activity with these. Brexanolone acts like what's called a neurosteroid in the brain. And we don't even know exactly what it is that neurosteroids do or how they function, but it seems that they're responsible for sort of overall control of brain signaling and helping to promote that pruning process I was talking about, the kind of nerve growth where it's needed and the nerve clipping out where it's not needed. And so the brexanolone is known to really rapidly increase the amount of a brain chemical called BDNF, brain-derived neurotrophic factor. And that's what makes it so your brain can do that pruning activity. So far, brexanolone is only used for postpartum depression. And it's a 60-hour infusion. So it's only by an IV. So this medication has kind of a narrow window that it would be used in and a narrow group of people that it'd be used for right now. But there's a lot of research going on right now trying to look at chemicals that are really similar to brexanolone and can they work for depression outside of postpartum depression. So we may see other medications in this category that get used in other circumstances. And then esketamine, yes? It does. So they use brexanolone for postpartum depression. It works very quickly. I want to say it's like 75% of women have achieved remission from their depression, like no depression symptoms at the end of the 60-hour infusion. The lasting effects of the medication are uncertain at this time. So it's likely that there may be need for maintenance antidepressant going forward. Yes. Yes, there's a major difference between that and ketamine. Ketamine also, though, increases the amount of that BDNF in the brain very rapidly, but it does it in a totally different way. And we don't even understand exactly how it does it, but it lands at receptors that are called NMDA receptors. They have a really complex function, but it's very regulatory in the brain, so it regulates a lot of other processes, this NMDA system does. And esketamine has been shown to bring about remission, again, of depression for people like within 45 minutes to an hour. I mean, previously unheard of kinds of results. But the effects are not sustained very long at all, not even a week, typically. So the way this medicine is used now is it's a nasal spray, and the patient who is prescribed this medication actually can never be in possession of it by themselves. The medication has to stay at a healthcare facility, and they have to be observed whenever they're like touching the nasal spray. It's a little bit of overkill maybe, but so like let's say I'm prescribed esketamine. I'll have to go into the clinic 3 times a week to give myself this nasal spray because I can't take it home with me. And then I have to stay in the clinic and be observed for 3 hours each time I give myself this nasal spray, so 3 times a week, because it can cause really big spikes in blood pressure. So I have to have my blood pressure monitored like hourly for 3 hours before I can go home. So it's not real practical for a lot of people right now. But again, there's a lot of research happening with chemicals that are really similar to S-ketamine to see, can we, one, make it less risky, and two, can we make it so they can take it home and actually use it in a more user-friendly kind of way. So I expect we'll see additional kinds of medications that are like it in the next few years that are going to be useful too. So there's a lot of promise with antidepressant treatment going in totally different directions than it has for the last 4 decades or so. That's a great time to take a break, I think. All right, should we come back like in 10 minutes? Okay, so that'd be like 10:25.
Yeah, I'll text her. they cancel on me because,
Yeah.
you know, they just don't
Yeah.
cancel for.
Yeah. I have a few where I think for the rapport building will really help with them and being available, but
Yes.
so they're giving my house is working.
Oh,
I don't want Jay to come over and make me clean. Yep.
yes.
But yeah, it's fun. Yeah, exactly.
You know,
I do what I can to make it fun, but
but, no problem. Yeah, she went to a previous church. Church, yeah. No, she used to do church at the other. Thank goodness. And, yes, she did, yes. Still, she does, and what we do, we're just, she's been generations.
no, it's one great.
Yeah, I heard.
Oh yeah.
Is it? Yes.
Cool.
So I'm
Must be
like,
a little different presentation.
yeah, and it's really, she's running the one.
Yeah.
And she did that, and she did two dance happening.
Yeah.
And she came back. Yeah, and, that's somebody in my day.
Yeah. Yeah. And that was my only thing. I was like, dang it.
I know. Yeah, but,
I'm searching for this each time I
yeah,
present.
well, I'm sure you did.
Yeah.
Yeah, yeah, yeah.
Now you're asking questions.
Yes.
You're taking notes.
Yeah, I know.
Yeah, for sure. Good speaker. I do not like. I purposely took speech class in the summer before my COVID year with like 4 other people. I did it by me.
Oh, no, I usually, I never did speech debate in high school.
And I fought the people I do. And it's a skill and a talent. For sure.
Some people have it.
Especially in speech when it's the, it does the, what is it? There's the one competition where it's like, you have like 5 minutes to look at something and you have to come up with a speech or something.
Oh, okay. I don't know. Yeah, I would freak out.
Me too.
I would be so anxiety ridden that would have been. I can get out and say a prayer in church if it's written out.
Yeah.
And I have taught celebrate recovery.
Yep.
So, it's that,
Yes.
yes, yes.
Okay, it's like 10:26, so I think we'll begin again. And the goal is to be done be done talking by like 11:10, so we have time for question and answer if needed at the end. I know you've been asking questions throughout, and please continue to do so, but we'll save some time at the end also. Claire, will you go to the next slide? So the tricyclic antidepressants are an additional class of antidepressants. So you're probably getting the idea that there are a lot of antidepressants, and that is the case. There are, like, I can honestly say I feel like I've never run out of antidepressant options for a patient that I've been working with because there are so many. Now, not all of them are going to be drastically different from their cousin in the same class, but there's still options. The tricyclic antidepressants are a much older group of medications. They were the kind of prime time go-tos in the 60s, 70s, maybe 80s, before the SSRIs and any of the other antidepressants we talked about today, before all those came out. These still have their place, but they're not used very commonly anymore because they have a much greater risk of a lot of different side effects. So not only do they have a higher number of possible side effects, but they also have a greater risk for any of those side effects occurring. Most commonly, we see people have a lot of dizziness when they take these, a lot of sedation, like feeling groggy and sleepy. And they have the potential to cause some heart arrhythmias, making your heart beat irregularly. So we tend not to use these very often. Another concern about them is that they have the potential to be fatal when they're taken in overdose. And the other antidepressants we've talked about today do not have that potential, at least not with any great frequency at all. And sometimes people kind of, like in the healthcare system, will sort of keep that information close to their chest. I don't believe in that. I feel like people who are going to be taking a medication should know whatever they want to know about it, including its potential harms. But that means that we sometimes don't have people take a full 30-day supply of this medication home with them because that might increase temptation, or if they have impulsivity, that might be really dangerous for them. And so sometimes we'll just have people take a 7-day supply of one of these medications at home, or take that home at a time, and go back to the pharmacy for refills just to make sure that they're safe with having this medication prescribed to them. The instances where we might use one of these medications would be if someone has chronic pain, because these work similarly enough to the SNRIs that they can actually address chronic pain in the same way as that we talked about with those medications, blocking the brain's ability to perceive those pain signals. And blocking probably isn't even the right word, but reducing maybe the brain's ability to perceive pain signals. And then one of the things about this group of medications that's different from any other, is that we can actually measure the amount of these medications in someone's blood and correlate that with, is their dose high enough to give them benefit from the medicine? The rest of the antidepressants, that doesn't work out. The amount that's in someone's blood doesn't correlate very well with the amount of activity that it's doing in their brain. So measuring the amount in their blood doesn't really help us to see if it's working or not with all the other antidepressants. But these ones, there's a correlation between how much is in the blood and how well it's working in the brain. So we can actually measure the amount and then adjust the dose based on that. That's not necessary in very many cases, but once in a while we use one of these for that purpose. Anybody have any questions about those other than what I talked about? Because, like I said, they're not used that commonly, so we may as well not spend a lot of time on them unless there's specific questions. Okay, next slide, please. I think we have actually covered pretty much all of the information on the general treatment principles slide. So this information basically applies to use of any antidepressant, regardless of which of the categories it falls in. So we know that major depressive disorder has a high recurrence rate, and you can see the frequency with which the research shows that people will have recurrence of their depression. So if you've had one episode, there's a 50% chance that you'll have another. If you've had 2 episodes, there's a 70% chance you'll have another. And if you've had 3 episodes, there's a 90% chance. And that's why we kind of differ the recommended length of time with an antidepressant based on the number of episodes someone has had before. Because if they've had more than 2, we really want them to be on a supportive maintenance medication to hopefully help reduce their risk. And these percentages are based on untreated depression, by the way, not treated depression. We talked about the taking 6 to 8 weeks to see full effects. Sometimes you'll see 4 to 6 weeks, sometimes you'll see 6 to 8. It's a range in there. We talked about avoiding alcohol and other substances. The efficacy between the agents is roughly similar. We talked about that with the SSRIs and SNRIs, that about the same number of people who take any one of those medications will get better. But for any one individual, one medication may be way better than the other. And that's true with all the other antidepressants we talked about, except for brexanolone and esketamine. Those have higher efficacy rates, quite a bit higher. But they're still kind of in a narrow niche of treatment right now because we're still learning so much more about them and trying to make them more user-friendly. Okay, next slide. I think we also have pretty much covered, that's really hard to see, and on this copy it's impossible to see. Yes?
I had a question. Can you speak to the efficacy of physical exercise for treating depression, either compared to or in conjunction with any of those medications?
Sure, great question.
How that works?
Great question. So we were talking about this a little bit on the break too. The question was about, can I talk to the efficacy of physical exercise compared to an antidepressant or in conjunction with an antidepressant? I don't know the exact statistics for sure, but for sure, like with anxiety, without a doubt, exercise is the most effective treatment. Physical exercise and breaking a sweat and getting your breath to be, like making yourself feel like you have to breathe heavier. Doing that for 20 minutes, 3 times a week is the best treatment for anxiety that we know of. And most research studies that have used antidepressants have had some form of non-pharmacologic therapy as the baseline for everyone. So let's say you're going to enroll in a clinical trial that's going to use an antidepressant. They're going to expect you to follow a lifestyle protocol that probably includes exercise and probably includes attending appointments with a therapist. So that's kind of like the baseline of what we expect antidepressant treatment should be built on top of. And I'm glad you brought that up because I don't think that often is communicated and maybe not even carried out very often. But really that's what we would expect will give us the best overall outcome. I haven't seen really studies that have compared just exercise to just medication. I think those would be a little bit confounded. Like it might be difficult to tell if there's a true difference for lots of various reasons, including people's adherence to the protocols and things like that. So I couldn't speak to that, I guess, very well. But I mean, I'm a pharmacist. I know medications. I work with them a lot. A lot of people who are like me are like default medication is the first thing we should do. This is always the recommended approach. I don't think that's true. I don't think for most people an antidepressant should be the first thing that's tried for their depression, and really exercise, therapy, supportive community should come first, and then antidepressant after that if still needed. I'm like selling myself out of a job by saying things like that, but maybe I'll get paid to talk about that someday. We'll see. I guess I technically am on the clock for my job now, so. Okay, duration of use. I think we covered this. Yeah, I don't really think there's anything much else to say except for that I kind of divided the start of an antidepressant into a few different phases of time. So the acute phase is when you're starting the medication and we're monitoring to see is this going to work or not. Everybody needs to go through that when they're starting an antidepressant. That's just kind of how it goes. And then if the antidepressant that you start works, then you would proceed into the continuation phase. And that's the remainder of a 12-month time frame from when you started to getting to 12 months. Okay? And that's recommended for everyone also. It's, I think, fairly common in American society that people start taking any medication, but including an antidepressant, feel better after a few months, and they're like, oh, I don't think I need this anymore. I feel better. Well, that's really not at all recommended. That's associated with a lot worse outcomes than continuing to take the medication for that full year and then evaluating after that. And then just a reminder that if you have had more than 2 episodes of depression, then the maintenance phase is also recommended, which is continuing the antidepressant for at least 2 years, but maybe indefinitely, depending on the severity of your episodes, the frequency, your life circumstances, all that kind of stuff. The next slide talks about discontinuation or withdrawal syndrome. I don't like the term withdrawal syndrome related to antidepressants because I think it makes it sound like they're addictive, because substances of abuse are associated with withdrawal. So I prefer the term discontinuation. You might hear people call it withdrawal symptoms, though. Just remember that that's not the same as withdrawing from an addictive substance. The brain processes are completely different when we're talking about excuse me, an antidepressant and stopping that cold turkey compared with stopping an abusive substance cold turkey. My throat and voice are starting to give out on me, so I apologize if I have to clear it a lot. Okay, the next slide leads us into talking about anti-anxiety medications. And of course, we've already talked about, next slide again, that the antidepressants are the first-line treatments for anxiety. That's what we're generally going to use. And when I say first-line treatments, I mean first-line medication treatments, not necessarily first-line treatments over and above exercise, supportive community, and psychotherapy. Because those, for many people, will be first-line before they use medication. But the next slide brings us to the class of medications called the benzodiazepines. And these are commonly used to treat anxiety. And they have a very different role than the antidepressants do in treating anxiety. But I don't think this gets communicated to the people taking these medications very often at all. But I would argue that it's really important. So these medications work very rapidly. Most of them will begin to work within 15 minutes to maybe 60 minutes for the ones that take the longest. But they don't last very long at all. The effects of them are not likely to last more than 24 hours. And for like the top one, alprazolam, and the bottom one, lorazepam, they don't last longer than a few hours at a time, maybe 6 hours total. And they don't work with the chemical serotonin at all. They work with the chemical called GABA. And GABA, I always describe as like the brakes in your brain. So when GABA is acting in your brain, it's just like your brain is slamming on the brakes. And it's slamming on the brakes with all kinds of electrical signaling that's happening, not just anxiety signaling. Okay, we want anxiety signaling to slow down. That's the goal of treating anxiety, right? But we don't necessarily want thought processing signaling to slow down, or decision-making processing to slow down, or memory formation processes to slow down, or even balance and coordination processes to slow down. But when GABA is working, it slows down all the brain processes, okay? So these medications make it so that GABA can get into its spot that it needs to land in the brain to work. These medications make it so that spot gets opened up wider and GABA can get in better. So it's kind of like if you think about the spot where GABA needs to land as a closed flower blossom, these medications make it bloom and open up. Okay, so if GABA was a bumblebee, they can get into that flower much more easily, right? So that's what these benzodiazepines are doing. They're making it so that the GABA can get to where it needs to go much better, which sounds great. And they are very effective at reducing anxiety symptoms very rapidly. And if that's all they did was make anxiety slow down, they would be miracle drugs and we would all love them and we'd probably all have them in our medicine cabinets all the time. But that's not all they do, not even close. I already mentioned that they slow down all different kinds of signaling in the brain. So they have the side effects of making people feel tired and groggy and kind of foggy. They can make people fall because their balance is impaired. They are actually now pretty well documented to impair memory formation. So both short-term memory formation and even long-term. They also have been associated with increased risk of dementia when they're taken for long-term use. So that's from the GABA action of these medications, that's stepping on the brakes in the brain. They also impact dopamine at the exact same time. And dopamine, you may recall, is typically what we think of as our pleasure chemical. When we do something that our brain experiences as positive, we get a little spurt of dopamine in our brains. So I mentioned this before, but when you exercise, you get a spurt of dopamine in your brain that tells you that was a positive experience, it's reinforcing, it's something you should do again. It also causes your brain to take a little snapshot of what was happening at the time that you got that dopamine spurt, because that helps you to deepen your recollection of that experience, that was a good thing and that you want to do it again, okay? So you begin to associate situations and cues with getting that dopamine spurt, because that's how your brain entrenches that into sort of your network, that this is a positive thing you should do, and you get cues to do it again. So because these medications cause a little spurt of dopamine in the brain, they are also something that they bring about an experience of pleasure. Now, when people take these, I have asked lots of people, do you feel like you are on a high or like you have a buzz when you take one of these? Almost everyone says no. I don't feel like I'm high or I have a buzz. But if I say, when you take this medication, do you get this feeling? Everyone says, yes, I do. I know what you mean. Well, that's not the same thing as having no anxiety or having your anxiety relieved. Having anxiety relieved is just you're not anxious anymore and you're able to think about something else or you're able to enjoy something else. That relief, that sensation where you take a deep breath and you're like, ooh, that feels good, that's dopamine. And I mean, that's not a bad thing. Having dopamine is good. Everybody needs that in their life. But having that happen directly after you take a medication, at the same time that your anxiety is relieved, is powerfully reinforcing for your brain that that's what you have to do to get your anxiety relieved. That's not true. Okay, but that's what the brain starts to tie all together when these medications are used, especially if they're used long term. And so the end effect that we now understand better is that when these medications are used long term, they can actually make anxiety worse because your brain is constantly chasing that feeling of, and it gets harder and harder to get. Plus, your brain kind of gets tricked into thinking that it can't get relief of anxiety in any other way unless it gets that feeling.
So
These are addictive, yes. So I don't want to paint these as like evil or bad medications. They definitely have a role, and they're very helpful in short-term use. And that's the best use of them, I would say, is like, let's say you're just starting to take an antidepressant to control your anxiety. Sometimes people will be prescribed one of these for a few weeks because we know the antidepressant isn't going to work right away, right? It's going to take a while. And it might actually make anxiety worse while you're waiting for it to kick in. And so sometimes these can help to bridge from when you start taking the antidepressant when things are real bad to when the antidepressant starts to work. Okay? That's probably the best use of these medications. Now, everywhere I've ever worked and talked to patients, it ends up that there are lots of people who take these long term. They have taken them for years, sometimes decades. It is what it is. That's probably not the thing we would have ideally wanted to do from the get-go, but we always have to make decisions about what's the best balance of risks and benefits for any one individual. Okay? So I'm not trying to say that everybody who's taking one of these medications and has been taking one for longer than 12 weeks should stop. That's not the case. But it is, I think, healthy to think about, is this still in my best interest? And have a conversation with providers about that. And have your clients have conversations with their providers about that. Is this still in my best interest to keep taking one of these medications? Is it leading to more benefits than it is harms? And for a lot of people, that might be yes. It is leading to more benefits than it is harms. That doesn't mean there are zero harms, but maybe the benefits are greater than the harms. What we would never want someone to do is stop taking one of these all of a sudden. They're addictive for one thing, so there's going to be a withdrawal syndrome that will happen when people stop taking them. There's often a really marked increase in anxiety and insomnia. People will often have tremor and a lot of just physical discomfort when stopping these abruptly, and they can contribute to seizure when they're stopped abruptly. If you think about your brain's gotten really used to having the brakes stepped on regularly when these are being taken long term. So it actually compensates and it increases its own activating signaling. It steps on the gas, essentially, because it's gotten so much braking activity. It's got to, speed up its own processing a bit. And so when your brain has been getting brakes stepped on a lot and it's increased its own gas pedal activity, if you take away the brakes all of a sudden, you're left with a lot more gas pedal activity than you started with. And that's not good. That's what causes seizure. That's what makes you feel really yucky and overactivated and kind of just honestly, like you can't control your own thoughts or anxieties or whatever when these are, or get yourself to go to sleep when these are stopped abruptly. So always, always, always taper them if they've been used on a daily basis for longer than 12 weeks. Now, some people will have these prescribed to them as needed. So they're just going to take it, maybe, they're having a really bad day, their anxiety's real bad, they got to get on a plane, or, their mother-in-law is coming to stay, or what have you. And that's appropriate, that's fine. If they're going to be used on a daily basis for several weeks in a row, then we want to reevaluate. Is this in my best interest? Is this in my client's best interest? Is this bringing about more benefits than it is harms? They're going to keep using it on a daily basis for several weeks in a row. But occasional use, once a week or once every 3 days, when you got to, I don't know, do something that's uncomfortable or hard to cope with, that's usually acceptable and considered low risk. Let's see, these medications, so we talked about antidepressants and combining them with alcohol and other abusive substances, and nothing really severe is likely to happen immediately, but it's undermining the effect of the disease control and the medication. This is a completely different picture when these are combined with alcohol, because alcohol does the exact same two things that these do. Alcohol steps on the brakes in your brain by acting on GABA, making GABA more effective, and alcohol causes a spurt of dopamine in the brain. So combining these with alcohol is quite dangerous. There can be enough braking activity in the brain that people have actually stopped breathing when they combine enough of one of these medications with enough alcohol. So the answer about is it okay to have a little bit of alcohol with these is different than an antidepressant. The answer is no. It's really not okay. Yes?
Can I just say to our staff, I think we know that this is one of the categories of meds that is used quite a bit, and one that I think we should be conscious of in their possession. You know that somebody, so I might as well do it. Thank you.
Mm-hmm.
I could have come and got that. For those who are watching online, if there's folks watching online, I just mentioned to our staff, we know these are a category of meds that are often used and abused by people that we work with, and that we should be conscious of that. So that was very helpful information. And somebody's going to ask, the most common thing I hear now is that I use a natural product for my anxiety, a THC product or marijuana.
Sure.
So you might as well address that.
Okay.
If you could.
We know a whole lot less about THC or marijuana and its effects in the brain than we do about these medications. So I want to start with that as kind of a disclaimer that what I'm saying is mostly theoretical or anecdotal, like based on a few experiences or a few small studies, whereas we have literally 6 decades of research with the benzodiazepine medications, and we know exactly what's in them every time someone's taking one. So you can probably guess where I'm going with this a little bit. What we understand so far about THC, and let me back up, what we understand so far about cannabis forks when we start thinking about THC versus CBD, okay? So those are 2 different chemical entities that are in the natural plant. And THC is what contributes to the euphoria when someone uses cannabis, and CBD is what contributes more to the sleepiness and the appetite increase, probably. THC, in terms of brain chemical activity, the end result of acting on cannabis receptors in the brain seems to be very similar, neurotransmitter-wise, brain chemical-wise, to what a benzodiazepine does. Steps on the brakes and causes a spurt of dopamine. So we're hearing reports that THC is helpful for anxiety, and I believe that is probably true, just like benzodiazepines are helpful for anxiety. In the short term, while the chemical is still in your brain, yes, anxiety will feel relieved because the brain processing is slowing down. That contributes to anxiety signaling. And there's this association of pleasure, so that can make it feel like anxiety is being overridden. Long term, I think there's likely to be the same problems with cannabis, or THC especially, as we see with benzodiazepines, where over time the brain increases its own gas pedal activity to overcome that braking in the brain, and that contributes to increased anxiety. And the same issue of the brain tying together the dopamine spurt with anxiety relief and thinking they're the same thing. So then kind of being tricked into thinking it can't get anxiety relief without that happening, without getting that spurt of dopamine. We know that that's not actually true. People get anxiety relief without getting a spurt of dopamine, but the brain can be easily tricked into thinking that's not the case. So I am very concerned, actually, about THC use for anxiety. I think we have not done enough research to understand if what I've just described is really what will play out. The early understanding of its pharmacology, to me, indicates that that's probably what I would expect, but we haven't done the research to indicate if that's the case. And the little bit of research that has been done on THC and anxiety is really difficult to trust because, as you probably are aware, cannabis products can have completely variable compositions. There can be some products that have only 10% THC and some that have 90% THC. And the potency of that difference is really, we would expect completely different things from a potency of 10% or a composition of 10% THC compared to a 90% THC composition. But in some studies, the people who are taking those two different compositions are just lumped into one group. So it looks like whatever results they got, it should apply to all THC, but that's not the case. So I personally would not recommend that someone use THC for anxiety or any mental health condition at this point. I just don't trust that we have enough understanding to say that it's likely to lead to more benefits than it is harms. There's a possibility that we will get research down the road that does show us, yes, there are more benefits than there are harms for some people, or maybe for everyone. I doubt that, but maybe. So I'm not closed-minded about cannabis and its potential, but I don't think we're ready for it to be used widely for mental health conditions right now. CBD, I'm a little more hopeful about. It does not have the dopamine spurt that THC does. So it's more of a regulatory activity in the brain rather than an abrupt and rapid activity in the brain. So consequently, people tend to say, well, I don't think that works very well for anxiety. Well, that's because it's not giving you a dopamine spurt. It's not making you go all of a sudden, you know? But long term, it might actually contribute to better regulation of other neurotransmitters in the brain. But we don't have the research to say that with a lot of confidence yet either. And the same problem that I described with the THC compositions has happened with CBD compositions also. Sometimes there are products that have 90% CBD plus some other additives, and there are some that have 10% CBD plus a whole bunch of THC. And they're sometimes lumped into the CBD group and described as though their outcomes are the same as people who are taking 90% CBD. So it's very muddled, it's very confusing. You get a lot of mixed messages in the media and from people who've tried various CBD or THC products or are using cannabis medically. I'm just very hesitant. I'm hopeful, but I'm hesitant that I don't think right now is the time to start using those products for mental health reasons. Yes? Does that include street and dispensary? I would be even less trustful of street obtained sources compared with dispensary. Dispensary sources do have pretty careful delineation of what the composition of their products are. But like, for example, in Minnesota, the law states that a pharmacist has to determine the formulation that someone should be taking for whatever condition they're treating with cannabis. But we get exactly zero instruction in pharmacy school about how to dose cannabis or what compositions are good for what conditions, because there's no evidence, there's no research to show how you should do that. And so in pharmacy schools, we teach what the evidence shows, and there's not evidence to teach. So it's kind of a conundrum. We can't get the evidence unless we do a lot of research, and cannabis is very highly regulated right now, so it's hard to do research, but we can't confidently recommend it and use it safely until there's research. So it's kind of a vicious cycle. I think we'll get there, but like I said, I just don't think right now is the best time to rely on that as your only treatment for a mental health condition. And in terms of combining a cannabis product with an antidepressant or a benzodiazepine, for example, that makes me really nervous because as I already talked about, when substances of abuse are used, and I'm using cannabis right now to describe it as a substances of abuse because of how much dopamine gets dumped out when a THC-based product is being used, that causes a bunch of disarray of the neurotransmitters in the brain. It's like, I think of it as like a light bright. Do you guys remember light brights where you made a pretty picture by plugging all those pegs into the box? I'm dating myself, but. So substances of abuse, including cannabis, anything that causes a spurt of dopamine in the brain, it's like taking the light bright and turning it upside down and shaking it till most of the pieces fall out. Okay, so if your antidepressant medication is trying to make a nice picture on your light bright, there's the potential that cannabis or alcohol or heroin or whatever is dumping it out, shaking it and making the pieces fall out. So any of you who, like your dispensary or you're good friends with your dispensary folks, I'm not trying to tick them off or anything. I think there is great hope, but I just am concerned about the potential for greater harm than benefit right now because we don't understand what we're doing. Yes?
Does CBD have anything in common with melatonin?
That's a good question. Does CBD have commonality with melatonin? The only commonality that I can think of right now is that they both have some regulatory action on sleep. So CBD uses a completely different receptor system in the brain than melatonin does. But they both kind of connect to the center that causes you to feel sleepy. Other than that, they're very dissimilar and unrelated. Yeah. Good question, though. Thank you, Dale, for that controversial but important topic. Any other questions along those lines? Okay, if you'll go to the next slide, Claire. So this just adds a little bit more information about the benzodiazepines. I think I have actually really discussed pretty much all of this. I didn't define rebound insomnia that you see as an adverse reaction there. That means that when you've been using a benzodiazepine to help you fall asleep, and then you maybe don't use it, let's say for a night, you may have worsened insomnia than you had to start with. And that's based on that extra gas pedal activity that the medication causes your brain to do in adaptation. It's a form of kind of withdrawal effect. And I don't know how familiar you are with the difference between tolerance and dependence, those two terms. Should I talk about those? So tolerance means that a person needs more of the substance to get the same effect. And dependence means that there's a physical adaptation that has happened to the presence of the medication, and that without the presence of the medication, there's a syndrome of symptoms that happen. So tolerance and dependence are not the same thing. And all by themselves, tolerance and dependence, or even both of them occurring at the same time, do not mean someone's addicted. So we expect, actually, that tolerance and dependence will both happen when someone's taking a benzodiazepine long term. That's just how the brain responds to having one of those medications around. But we do not expect that everybody who takes a benzodiazepine for long term will become addicted, meaning that they'll use it for other reasons, they'll use it solely for the purpose of experiencing pleasure, they'll spend excessive time thinking about how to obtain and use the medication, they'll abandon their other responsibilities in order to focus on using the substance. Those would be consistent with addiction. But tolerance and dependence, while they almost all the time happen when someone develops an addiction, those two things in and of themselves do not represent addiction, or that someone's in an addictive pattern. Clear as mud? All right. Okay, I think that pretty much covers what I had in mind to talk about with the benzodiazepines. So we can move on to the next slide, which is the antipsychotics. This group of medications, there's a lot of complexity with these medications. They work on multiple brain chemicals at the same time, and they have very differing kind of potency with which they each will act on the various neurotransmitters. So I'll just give you a quick example. Olanzapine, which is Zyprexa, it works really pretty potently on blocking dopamine. Now you might think, who would ever want their dopamine blocked? Because how do you experience pleasure if your dopamine is blocked? Well, these block dopamine in a different area than the pleasure center in the brain. Okay, these block dopamine in the kind of thought interpretation center in the brain. And so blocking dopamine in that center in the brain makes it so that if people are experiencing hallucinations or delusions, that they will experience them less, or that they'll be able to recognize that they're not real. But the medication aripiprazole, which is Abilify, that's on the right-hand side on this slide, while it also works on dopamine, it blocks it with way less potency than Zyprexa does, or than olanzapine does. So they both can be used to treat diseases that have hallucinations or delusions, but we just expect a lot of different side effects and beneficial effects between those two medications, even though they're in the same category and their mechanism, the way they work, is technically the same. So it's really difficult to generalize really anything about these medicines across the whole group of them because they're so different, even though they're in the same category. So if you've taken one antipsychotic, you've taken one antipsychotic because they're all really different from each other in the way that they cause side effects and beneficial effects. The most common, probably the most frequent, I guess, use of these medications nowadays is as an add-on to antidepressants. There's really good research supporting that most of the medications in this class, when they're added onto an antidepressant for someone who's gotten a partial benefit from their antidepressant, that these bring about more improvement than the antidepressant alone. Now, we don't start with these medications, and we're not going to add them on for every single person who's taking an antidepressant. But if someone has taken an antidepressant for at least 12 weeks, and they've gotten somewhat better, they're maybe 50% or 60% better. I know that's really hard to quantify when you're really just talking about, well, I used to be able to not get out of bed, and now I kind of can. But that's the kind of thing I'm talking about. We might add one of these medications on. But if someone's taking an antidepressant and they've gotten almost no benefit or none, then it doesn't make any sense to add one of these on because we're not going to be able to boost anything. If it's not working, it's not working. But if it's partially working, then we can use one of these to kind of boost the benefit and hopefully get all the way to remission of depression symptoms. So the name antipsychotics is kind of misleading because taking one of these really does not mean that someone has any form of psychosis or needs to treat their psychotic illness, because that's not the case. We use these for people who've never had hallucinations or delusions and probably never will. And they don't increase the risk of experiencing hallucinations and delusions in someone who's never had them. There's no risk associated with that. I've had people ask me, well, does that mean that I could develop schizophrenia if I take an antipsychotic? No. There's no risk for bringing about new hallucinations or delusions if you've never had them before. These medications, if you pick one up from the pharmacy and you get the medication information sheet about them, or you Google the side effects of an antipsychotic, be prepared to be scared, honestly, because there is a long list of possible side effects of these medications, and it sounds really frightening. But they're not. They're not frightening really at all. And most people who take them tolerate them very well. But there's a lot of possible things that we have to monitor for when people are taking them because they're rare and they can be serious when side effects like that occur. A few of those are what we call a kind of cluster of metabolic effects. Metabolic meaning like how your body metabolizes your food and gets rid of it. So they can cause weight gain. And they can cause increases in cholesterol and increases in blood sugar. And the way I just described that is potentially a little misleading, so let me back up. They don't actually change your metabolic rate at all, but they change your brain's ability to recognize when you're full from your food and satisfied from your food. And so it turns out that people actually eat more and eat foods with higher intrinsic satisfaction values, so foods with higher sugar content and higher fat content, because they're chasing that I want to feel satisfied feeling. So that's where the potential for weight gain comes in. We know that it is preventable. Weight gain with these medications is preventable, but it takes a lot of self-regulation to eat foods that are healthy and to not eat larger portions or eat more often, because your brain's going to be sending you signals that you're still hungry and need to eat again. Another cluster of side effects with these medicines is related to movement kind of control. So people can develop what looks like Parkinson's disease when they're taking one of these medicines. So they can have a tremor, they can have kind of a stooped posture, their facial expressions may change less. That's all part of what's called pseudo-Parkinsonism. So it's false. That's what pseudo means. It's false Parkinson's disease caused only by the medication and has no bearing on whether someone will go on to ever develop Parkinson's disease, the real disease. But it looks like Parkinson's disease while they're taking one of these. Sometimes people also can have what are called acute dystonias. And that's basically like a Charlie horse, but in your neck or facial muscles rather than like in your calf. And those are uncomfortable, as you can imagine if you've had a Charlie horse before, but very treatable and reversible. There is one kind of movement disorder called tardive dyskinesia that can occur with these medicines, especially when they're taken long term, and that's not reversible. And that involves often facial or, well, I guess your eyes are part of your face, eye movements, sometimes other movements in the body, but much less commonly. And they're often kind of rhythmic or repetitive, and the person themselves often doesn't even notice that they're making them. So it can be like lip smacking or chewing movements, frequent eye blinking or maybe eye bulging kind of movements, sometimes head movements that look kind of like a tic. Those are all examples of tardive dyskinesia that we want to try to detect right away if those are occurring, because we can prevent their progression. We might not be able to make them go away entirely, but we need to adjust antipsychotic treatment to address them. There are like a few reports of tardive dyskinesia happening with antidepressants, but in terms of likelihood of that happening, we're talking about like 1 in 30 million if you're taking an antidepressant, compared to about 1 in 100 if you're taking an antipsychotic. Yep. Yes.
There's a commercial on now all the time about it, and isn't that to treat it?
Yes. Yes, there are 2 medications now that can treat that side effect. Yes, they're to treat tardive dyskinesia.
So it has a side effect, but so they would always have to be in the med.
Right. The medication that can treat that side effect doesn't cure it, but it can reduce the symptoms. Yeah. Antipsychotics tend to work more quickly than a lot of other groups of medicines, so we would expect that we'll start to see benefits within a week, and maximum benefit probably by 4 weeks when someone's been taking a consistent dose of one of these. And that's when they're used to treat depression, as well as when they're used to treat schizophrenia or maybe bipolar disorder. These are used very commonly in bipolar disorder also. I don't think I mentioned that yet. Let's see. I have some slides about bipolar disorder. I don't think we'll probably get to them, so I'll just kind of quickly explain. In bipolar disorder, people have depressions and then manias. So that's like 2 opposite poles of mood symptoms. And these kind of medications and another whole group of medications that are called mood stabilizers, they kind of help to put up a ceiling and a floor so that someone's mood can't go too far in any direction. But kind of get shunted back toward the middle, toward that, like, I feel fine, I'm good, my mood is in maintenance mode kind of environment, which is typically what we want. So these make it so that those severe episodes are less frequent and then less severe when the antipsychotic medications are being used. Yes? Good question. The question was, is that being in the middle, that mood maintenance, is that associated with why people say they feel numb? Well, probably yes and no. And we don't know exactly why that happens, that people feel emotionally numb, but I know exactly what you're talking about. I've heard that lots and lots. It might be that if they're previously used to having more extremes of emotion, highs and lows, and they no longer have those, that it feels like they're numb, or like they can't feel their feelings the way they did before, or even maybe their energy or excitement. And it also may be just that there's an effect of the medication by having their neurotransmitters manipulated and adaptations in their brain that just leads to an emotional blunting. We don't know for sure which is the case, but we know that people who don't have bipolar disorder and stay in the middle, they don't tend to report that they feel emotionally numb or blunted. So it's some phenomenon of either the disease or the treatment or both that we don't fully understand. Yes?
Is oxcarbazepine in that same class?
Oxcarbazepine is not an antipsychotic, but it is a mood stabilizer. So that's a little confusing because there's if you go forward 2 slides, Claire, there's a whole slide of mood stabilizers. Is oxcarbazepine? Yes, oxcarbazepine's on there. So these are all also medications that can put up a ceiling and a floor, but they're not antipsychotics because they work differently. And we would never use these ones to treat schizophrenia or even as add-ons to depression treatment much. But we use these for bipolar disorder all the time. So these are only mood stabilizers. They're not antipsychotics or useful for some of those other things that antipsychotics might be used for.
So you wouldn't recommend taking that with antidepressants?
Yes, you could take one of these with an antidepressant. That would be kind of a nuanced approach to treating bipolar disorder that hopefully is under the care of a experienced practitioner, because it's not out of the realm of possibility at all, but it's not exactly what we would think of as first-line treatment.
Have we talked about like trazodone or Vyvanse?
We have not. I'm trying to think if I have I don't think I have those on here at all. So trazodone used to be used as an antidepressant, but it turned out when we used it in the doses that were needed to help treat depression, no one could stay awake. So now it's only used really as a sleep medication in lower doses, somewhere between 25 and maybe up to 300 milligrams. At those doses, it really doesn't have much ability to impact depression, so we don't expect it's going to be helpful for depression, except for that it can help you sleep, and that in and of itself can help to improve depression down the road. Yeah. Side effect-wise, usually people tolerate it pretty well, but it can certainly cause some oversedation or kind of a hangover effect where you feel kind of the next morning. Taking it with food at night, some people have told me, helps to reduce that hangover feeling. So, Vyvanse is in a group of medications we haven't talked about at all yet called stimulants. And those are typically used for ADHD. They sometimes can be used as an add-on to antidepressant treatment to help boost the benefit, but there's a lot less evidence for doing that. They work by increasing primarily dopamine and also norepinephrine, so 2 chemicals we've already talked about today. And they are abusive. They have the potential to cause abuse because of that dopamine activity. And the reason we need or use that dopamine activity is that when people have ADHD, it's thought that they don't have enough dopamine to help organize their thoughts and filter out information they don't need to pay attention to. And so the extra dopamine that a stimulant like Vyvanse can provide can help them with thought filtering. Yes?
I've taken a number of different kinds of medications, and my weight my whole life has kind of fluctuated up and down, up and down. Can you name a list of medications that don't cause weight gain?
A list of medications that don't cause weight gain. And do you know, would we be picking from, like what kind of conditions are we trying to treat, I guess I should ask?
Antipsychotics.
Okay. Abilify does not tend to cause weight gain. Latuda does not tend to cause weight gain. This is of the antipsychotics, for those of you on the stream, I didn't say that. Ziprasidone does not tend to cause weight gain. Cariprazine does not tend to cause weight gain. Claire, will you go back to the antipsychotics slide? Because I realize I'm rattling these all off without anybody being able to see them. And brexpiprazole, or Rexulti, does not tend to cause weight gain. So there's actually a number of them that are associated with much lower risk for weight gain. And they're newer, so they're more expensive typically than the older ones that do cause more weight gain. All right, I think we're officially into Q&A time. We only have like 13 more minutes, so what do you got?
I would like to just ask something. I think one of the common things that we deal with the people that we work with in the programs is they can't afford their meds, so they're stopping them or have stopped them. Their doctor has quit or moved. They just have come out of a difficult period in recovery and now are trying to figure out what to do. But we work primarily with people who have somewhat limited resources. And I know you have some comments about that, but you know, we're continually, I think, dealing with people who have stopped or are at risk of stopping their meds, and it's not as simple as just go get a refill.
Yeah.
So.
So I've done a lot of research in this area with people with lived experience with mental illness, because it's something that I observed in my practice a lot too, and have been troubled by my whole career. Meaning, like, it makes me feel so sad, and like there's more we ought to be able to do. One of the things that I have found to be the most associated with people continuing to take their medications is talking about the benefits. Talking about what they notice about themselves when they're taking the medication compared to what they notice about themselves when they're not taking the medication, and kind of growing that insight into what does this do for me, and what are my goals, and how is what this does for me getting me toward my goals, or isn't it? And if it isn't, I mean, that's a very likely or possible scenario. Then it's time to talk about what do we need to do instead to get toward the goals. But if it is bringing about benefit, and even if it's just, you know, my family likes me better, or I got to be in my own apartment while I was taking these medications, sometimes it's hard to say, well, that's, you know, you got to be in your own apartment because of your medications. That's a, you know, how do we know for sure that that's the cause? But if you got to be in your own apartment while you were taking your medications, I think there's a significant possibility that that's a contributor to why you got to be in your own apartment and why you're able to live successfully and organize your life and do, you know, take care of your responsibilities and things like that. So I always try to introduce what are the possible benefits you've seen, and can you, meaning the person taking the medication, can you recognize what has changed in a positive way based on being on those medications, and then try to encourage, you know, what if you lost those benefits that the medication was bringing about by stopping them or making a change? How might you go backwards, and are you willing to risk that based on what you've experienced before? I don't believe in coercion or even using should statements, like you should keep taking this medication because blah, blah, blah. I believe in presenting the information and encouraging people to weigh the pros and cons and making decisions based on what they know is best for themselves. Because honestly, I'm not the one who has to take the medication every day. I'm not the one who has to experience the side effects or the harmful effects of either continuing to take a medication or stopping it. And knowing the information, I think, helps to make a decision that's in that person's best interest that they're willing to buy into. So that maybe sounds kind of Pollyanna, but that's kind of my underlying mantra. Yes?
So, not my doctor before you retired.
Maybe we should have, microphone.
So before my doctor decided to retire on me, we had talked about doing some DNA stuff. What are your thoughts on that?
Yeah, so I'm guessing they're talking about genomic testing. Is that sound right? Yeah. So I think there's a lot of promise for genomic testing. Right now, it's a little bit tricky because what the tests will tell us is basically the amount and speed of enzymes that you have based on your genetic coding. And enzymes, you may recall, are the things in your body that break down substances. So every medication that you take needs to get broken down. I shouldn't say every. Most medications that you take need to get broken down by enzymes in your body in order to get eliminated. So if we do a genetic test and we find out that your 2D6 enzyme, that's an example of one of the names of an enzyme, your 2D6 enzyme is really sluggish and you don't have very many, then that would tell us, well, if we're using a medication that gets broken down by that enzyme, we should use really small doses, or maybe we shouldn't even use that medication at all because it's going to stay in your body longer and you might have more side effects from it as a result. What the genomic tests do not tell us right now is which medication we should use because we don't have the information to get from people's genes what it is they need from an antidepressant. We can find out what might make them more harmed, but we can't quite tell yet what will make them more benefited, unfortunately. There's one exception to that, which is that if you remember in the picture of the nerves talking to each other, those receptors, those transporters, we can tell from your genes a little bit about how many of those transporters you make. And if you don't make very many, then we might not use the medications that work on those transporters because they just won't have very many places to do their job. But even when we have had that information in research studies and we use that to guide which medication to use, we still don't get that much difference in benefit over time. Like the group that we have the genetic information about, they don't do all that much better than the people that we don't have the genetic information about. Mostly it's because we can kind of start to predict some of what those genetic patterns probably are even before we get the test. Because if you've been on a medication that's metabolized by 2D6 and you had a lot of side effects, then I'm going to go, well, it's probably that they have a sluggish 2D6 enzyme, so let's use a different one, that kind of thing. So we have to start this way with genetic testing information because this is the road to how we get to what we really want. Like what's the cat's meow with using genetic information to prescribe medications. But right now it's still sort of chugging along and it's somewhat useful, but it's not anywhere near where the potential is. Yes?
One of the most medication commercials I've seen on TV now and heard about, talked about a lot is Ozempic.
Yeah.
And the use of stuff like that for weight loss.
Yes.
From my understanding, they were originally for diabetics.
Correct.
But now they're being more used for weight loss. I guess, do you see any benefit of using something like that with an antidepressant or primarily focus on just the antidepressant or something like that? And just what's your opinion on like Ozempic in general?
Yeah. So far, the research has not specifically studied using those kind of medications with antidepressants. There are some small studies that have looked at using those kind of medications with antipsychotics, though, and those have shown benefit. So I think that'll probably be the next step. Like maybe we should hire you in a research lab because you're thinking right along the lines of the experts. So I would expect we'll see results about that within the next 2 or 3 years about if that's a helpful combination or not. We do know that those medications cause some things that might bring about challenges like muscle wasting. And so including strength training when someone's on one of those kind of medications will be an important thing we'll have to recommend probably. And we know that if you stop taking one of those medications, the weight comes back. So a couple of caveats. But otherwise, I think they look like they're probably really promising. And they're not cheap. Yeah, good point. And they don't replace nutritional value of food. So focusing on what the nutritional value of your food is also an important aspect of weight control, not just a medication. Any other questions in the last 3 minutes and 3 seconds? Pardon me? I don't treat patients independently. I collaborate with people at Southeast. And that's it. So, for now, anyway. Yeah. Okay, well, thank you very much, everybody. It's been a pleasure. I've really appreciated your questions
Thanks.
and interaction.
Yeah, thanks for coming. Thanks if you watched on live stream, and Amy, thank you. Amazing as usual. So have a good day.